the topic is pressure volume loop curve. So we will definitely discuss pressure volume loop curve, but we have discussed already Wiggers diagram. So before the discussion of pressure volume loop curve, because there also we will compare a lot of things. So I'm just trying to compile everything together just to revise these concepts once again. See, we have discussed about Wiggers diagram. From this point, if you see till this point, from 0 to 80 mm of Hg, which is this phase called as isovolumetric contraction. From 80 to 120, rapid ventricular ejection. From 120 to 80, okay, it is slow or reduced ejection. From 80 up to 5, you can say isovolumetric relaxation, and after that there is rapid filling, and then it is reduced filling or slow ventricular filling. Clear? So this is the same Wiggers diagram in bookish manner. Now you can see one more. This is aortic pressure. Okay, because in the pressure volume loop curve, I will be comparing with the aortic pressure also. So for that you need this also. Aortic valves open here. Okay, then it is aortic valve closing here, and the place where aortic valve is closing is called as dicrotic notch. This is a separate MCQ. What is dicrotic notch? So the area where aortic valve is closing, we are getting a notch in the aortic curve. So in the aortic pressure curve, we are getting a notch, and that beautiful notch, okay, you can see here once again, this notch is visible. It is like this. So this notch is called as dicrotic notch. Then we can see we have correlated with the ECG also and the mnemonic which I have given, if you remember, revised tuberculosis program. Okay, and if you remember, R was S1 around, it is not just close to, T was around S2, P was around S4, so that in the exam it will be helpful. Now you can see here S1 was R, so you can see S1 and you can see the R, so they are in the same line, S1 with the R, and you can see S4 is with the P, S4 is with the P, and with the T you can see S2, not very close, but you can see approximately like that, that P is around S4, because S4 you will get when atria will contract, and P is atrial depolarization. Similarly, R, S1 is followed by IVC, isovolumetric contraction. So S1 then R, and T is ventricular repolarization. So S2 IVR. So this is S2, this is IVR T. And one thing more, ventricular volume. Pressure is increasing, volume is decreasing. Then in the jugular venous pressure, you must have seen AC, X, V, and Y. It was discussed in detail in jugular venous pressure video. So I hope this is clear. So just it is in a form of diagram, and everything is given in sync. So you can just see it in your book also and try to correlate. Okay, from 0 to 80 IVC, 80 to 120 rapid ventricular, 120 to 80 slow ventricular, 80 to 5 it is isovolumetric relaxation, less than 5 rapid ventricular filling, and then slow ventricular filling. Is this clear, doctor? The minimum you must need that, and just purpose of this diagram is to show you about aortic valve, so that you can have no problem when I will compare with Wiggers diagram. Okay, now I will draw a diagram for understanding of pressure volume loop curve. That was only a revision before the class, but this is the actual topic which I need to discuss in the class, and this is regarding pressure and volume loop curve. Regarding ventricle I am talking about. Now when volume is increasing from point A to point B, let me say A, B, then volume remain constant, then we can say like this. So I can, okay, A, B, C, and D. So if you see here, doctor, A is increasing and it becomes B. A volume will increase to become B. So at the end of diastole at point B, okay, we will have end diastolic volume. Yes or no? End diastolic volume. Or simply we can say preload. So minimum volume was A, maximum was B. And what is the maximum volume before contraction? End diastolic volume or preload. From point B to point C, you can see from point, approximately 0 to 80 mmHg. It is in all approximately 120 mmHg. So from 0 to 80 mmHg, it is your isovolumetric contraction. 0 to 80 mmHg. 80 to 120, rapid ventricular ejection. 120 to 80 again, slow ventricular ejection, and 80 to 5, isovolumetric relaxation. It is a tilted form. Okay, so once again, From A to B, what is happening from A to B? You can write ventricular filling. What is happening? Ventricular filling, or filling of the ventricle from A to B. From C to D, you can say ventricular ejection. Volume is decreasing. It can be rapid, it can be slow. And from B to C, it is isovolumetric contraction. From D to A, isovolumetric relaxation. Now, once again, from A to B, volume is increasing. From what? What is the minimum volume after ejection? And systolic volume. So, point A will be end systolic volume. And we have discussed in detail, end diastolic volume minus end systolic volume will be your, what is that? Stroke will be your stroke volume. I hope I have tried to clear the doubt, but we will recap again. Recap is very important. From A to B, ventricle will be filled. Okay. So it will start from end systolic volume. It goes to end diastolic volume. So maximum volume before contraction is what? Preload. Now, from B to C, volume is constant, but pressure is increasing from 0 to 80. So isovolumetric contraction. From 80 to 120, rapid ventricular. From 120 to 80, slow ventricular. From D to A, again, isovolumetric relaxation. Very simple. And B is end diastolic, A is end systolic, and between C to D will be end diastolic minus end systolic will be stroke volume. I hope there is no doubt in this, so that I can discuss applied also. So in the exam, they will ask you, what is the condition when you will get right shift of the curve? Right shift of pressure volume loop curve. Yes, tell me the answer, doctor. Of course, you know preload. So when preload will increase, what is the condition of right shift? When there is increase in the preload or end diastolic volume. So due to any condition which I will going to discuss after that, whenever there is increase in the preload, of course shift will be right. Now in the exam, sometimes they will ask you right shift is due to increase in the preload. So left shift will be due to, and maximum doctor mark after load. They are thinking that right shift is preload, so left shift will be after load. But it is not a poem. Okay, it is a science. Now just think it. Left shift means what is decreasing? There is decrease in the end systolic volume. Of course, if left shift is there, meaning what? What become less? If left shift is there, what become less? Let me make it. This is the right shift. In the right shift, end diastolic volume was more. But in the left shift, end systolic volume will be more or less, less. And you know, lesser is the end systolic volume. More will be the stroke volume. More will be the contractility. That is why before discussing about pressure volume loop curve, we have clear-cut idea we have about stroke volume, cardiac output, ejection fraction. Okay, all these terms we have discussed in too much of detail because it was needed in the exam. So now you can understand left shift of the curve is decrease in the end systolic volume, or stroke volume will be more, or contractility will be more. So sometimes they will ask you, if you give digitalis to a patient, shift will be right or left? Left. If you are giving digitalis to the patient, shift is going to be left. Why? It will increase the contractility. So right shift is due to increase in the preload, but left shift is not due to increase in the afterload. It is due to increase in the contractility. Clear, doctor? Now coming upward shift. See, normally aortic valve was opening at 80. Suppose it opens at 120 or whatever high. Okay, this is upward shift, and it simply means there is increase in the afterload. Very, very simple to understand now. Like aortic stenosis, like hypertension. So whenever aortic valve is not opening at 80, lot of afterload is there. It will open 90, 100, 120, whatever. It will increase upward. So upward shift of pressure volume loop curve is due to increase in the afterload. So once for all, right shift preload, left shift contractility, upward shift afterload. Sometimes in the same diagram they will give you, suppose 150 ml is end diastolic volume and suppose 50 ml is end systolic volume. So what is ejection fraction? Ejection fraction is equal to stroke volume upon end diastolic volume. What will be the stroke volume? End diastolic minus end systolic. 150 minus 50 upon 150. It come to be around what? Into 100. It will come in percentage. So it will come around 100 upon 150 into 100. Whatever may be the value, it is 1000 upon 15. Okay, something 15 6 is 90, 66.6%. So like that, they can ask you how to calculate ejection fraction. So I hope now these concepts are clear, doctor. This is about pressure volume loop curve. Now let us discuss something clinical. Shift in the pressure volume loop curve in different condition. Although only one point is needed to understood and to be remembered, but with a lot of physiology is needed. Sometimes if you want to score top 10 rank in your exam throughout India, whatever, okay, then you need to know more detail, more concept. So let us discuss. In aortic stenosis, at least now you are able to say in aortic stenosis, there is increase in the afterload, shift will be upward. You can see in this diagram. Okay, most of the time they will ask you only this much. In aortic stenosis, shift will be upward. But now let us discuss physiologically in more detail. When there is aortic stenosis, ventricle will try to contract hard. So increase in the left ventricular pressure, increase in the end systolic volume. Why? Because of the aortic stenosis, some blood will be left in the ventricle. Less blood will go. So more blood will left in the ventricle after contraction. So increase in the end systolic volume. Although if it is mild, no change in end diastolic volume. If it is mild, I'm saying. But if there is a change, it will cause decrease in the stroke volume. If it is a severe, moderate, and diastolic volume will, of course, it is all depending on the previous factor. So end diastolic volume is same, but end systolic volume is more. So stroke volume is what? End diastolic volume minus end systolic volume, and you are increasing this. So systolic volume will decrease, and ventricles are trying hard to open the aortic valve. So ventricular hypertrophy, and this will decrease the elasticity. Or this will decrease the compliance, not elastic compliance. Compliance is the ease of expandability. Okay, so because of hard contraction of the ventricle, there will be decrease in the ventricular compliance, and that is why, doctor, for given end diastolic volume, end diastolic pressure will be more, because now you have to contract more. So pressure will increase for similar amount of end diastolic volume. So these are different interpretation of aortic stenosis. This much is sufficient for what? For understanding of pressure volume will shift to up top, upward shift. But nowadays they're asking physiology of aortic stenosis. So these all are point regarding physiology of aortic stenosis. And you can see the red curve is aortic curve. So now left ventricle pressure will be high, higher than aortic stenosis, aortic pressure. So you can see here, it will go to the top. Clear? So in the aortic stenosis, see this diagram, imbibe this image in your brain. Same image they can ask you, and they ask you what is this? Answer is aortic stenosis. I hope every point is clear. We have discussed every physiology regarding aortic stenosis, not only pressure volume loop curve. Pressure volume loop curve is only this much, upward shift. But what are the different physiology happening in aortic stenosis? Things are clear. Now, second, aortic regurgitation. Now, if aortic regurgitation is there, doctor, when ventricles are contracting, okay, some blood is going back in the ventricle. Some blood normally, when ventricles are contracting, initially there was an isovolumetric ventricular contraction, then rapid ventricular ejection and slow ventricular. There were three phases. But now there is always a leaking, so you cannot get a true isovolumetric phase. When aortic valve and AV valve both were closed and ventricles were contracting, we got true isovolumetric relaxation. But here there is no true isovolumetric ventricular phase, because every time aorta is leaking. You cannot say aorta has a good hold, isn't it? And because of every time leakage of that, what will increase? Preload. Increase in the end diastolic volume, and more is the end diastolic volume, more will be the force of contraction, stroke volume. The stroke volume will increase. The shift will be on the right side. You can see here, shift will be on the right side, like a obese person. So that notch, normally when you are lean and thin, you have a different contour of the body. But when obesity is there, we will lose the notch. So dicrotic notch is gone. So loss of dicrotic notch. But this time we have large pulse pressure. See, now it is 120 and it is 50. Normally 120 and 80. So pulse pressure is what? 120 minus 80. But here it is 120 minus 50. So pulse pressure will also increase. I hope you will not forget this diagram, obese diagram. So AR are like obese. They're having diagram like that. Okay, AS and AR is clear, doctor. Now about mitral stenosis. when there is mitral stenosis. Okay, there is stenosis in the mitral valve, so left atrial pressure will be more, and blood coming to the ventricle will be less. So less end diastolic volume, less end systolic volume, and less systolic volume. Now, because of the mitral stenosis, not much blood is going in the ventricle, so not much stroke volume, not much end diastolic volume. So this is about mitral stenosis, and you can see in the diagram. See this diagram, you can see it was like a obese, and in mitral stenosis, what you are seeing? End diastolic volume is decreasing, and systolic is also decreasing. So you can see shift is like that in this direction, and diastolic volume is preload. So you can say preload will be less. Okay, so you can see this is shifted on this side. This is also a bit shifted. So this will be the image of pressure volume loop curve in mitral stenosis. Clear? And left atrial pressure will be more than left ventricular pressure. This is showed by this diagram. So main thing is that there will be shift in the pressure volume loop curve on which side? On the side of left. Here, compare with this diagram, it was on the right side. Shifting was right. And here there is shifting on the left. Now, mitral regurgitation. Mitral regurgitation. Now, what you will see? If mitral regurgitation, blood is leaking in the atrium, left atrium, okay. But every time when there is more and more blood, there will be more force of contraction. It will fill more and more. It will increase left volume also and pressure also. So it will cause more end diastolic volume also because of this. So here, increase in the end diastolic volume due to increase in the left atrial volume and pressure, and that will increase stroke volume because of forward flow, because of the Frank-Starling law. So more and more forward flow into systemic circulation plus backflow into the left atrium. So again, there is a leakage. Either there was a leakage in the aorta or in the mitral. In both conditions, one thing is common: no true isovolumetric phase. There is no true isovolumetric relaxation phase, IVR. So in both conditions, it was missing. Okay, and because of increase in the end diastolic volume, this will go to the right shift. Clear, doctor? Now let us compare again. This is aortic stenosis upward shift. You can see here. In aortic regurgitation, you can see here. Okay, just try to imbibe the diagram. This is your mitral stenosis, left shift, and this is your mitral regurgitation. Clear? Again, there is a loss of dicrotic notch, as well as there is no true isovolumetric phase in both conditions. In both types of regurgitation, there is no true isovolumetric phase. I know this topic is very typical. Normally, we study only this much. Right shift preload, upward shift after load, left shift contractility. But this is a bit more. Of course, you will not get direct question in physiology, but definitely in the clinical science, they will simply tell you about the valvular lesion and the murmur. And this is the physiology which can be asked regarding those murmur and all those things. So I hope this is going to help you. Thank you. All the best.